Chronic pain management during COVID-19 outbreak. Chronic pain patients may be more susceptible to COVID-19. Elderly patients and those with multiple comorbidities are particularly susceptible. Chronic opioid therapy may cause immune suppression in some patients. Using steroid in interventional pain procedure may induce immune suppression. What can we do while visiting patients in pain clinics? Many pain clinics may consider replacing face-to-face routine outpatient-based consultation with telephone or telemedicine consultation. But if you should visit the patient, please follow these rules. Place signs at triage points to instruct patients on appropriate hand hygiene, respiratory hygiene, and cough etiquette. Admit them on the scheduled time and only with face mask. Do not accept patients with fever or any respiratory symptoms. Limit unnecessary patient scores and create an area for separating patients, ideally at least 6 feet apart, in waiting rooms and at check-in or booking locations. When visit the patients, strongly consider using surgical, procedural, or both class face masks during any patient interaction. Do safe down and off PPE. Only urgent procedures are allowed during this outbreak. Suspend elective procedures, use telemedicine if possible, and determine elective or urgent procedure on a case-by-case basis. Urgent procedures are ITP refills and malfunction, device infection, deep infection, and which using explantation. The most common intrathecally delivered medication include opioids, baclofen, bupivacaine, clonidine. For opioids, clonidine and baclofen withdrawal would be expected with abrupt cessation, which can be fatal for baclofen. Evaluate other cases on individual basis and share your findings with other colleagues for better decision making. The goals are avoid deterioration of function, avoid reliance on opioids or emergency room visit, which increase the risk of exposure. Procedural scenario includes the intractable cancer pain management, acute herpes zoster or subacute intractable postherpetic neuralgia, acute herniated disc or worsening lumbar radiculopathy, intractable trigeminal neuralgia, early complex regional pain syndrome, acute cluster headache and other intractable headaches, other intractable medically resistant pain syndrome. When performing procedure with the potential for aerosolization such as intranasal sphenopalatine ganglion blocks and intraoral injection, using N95 mask should be used as recommended by the CDC and American Society of Anesthesiologists. Procedure should be performed with a minimum number of personnel, ideally by a physician with extensive experience to minimize the risk of exposure. Deep sedation that may require able support should be avoided in these patients. For using opioid use, telemedicine to evaluate and continue opioid therapy and ensure existing therapy to avoid withdrawal, provide naloxone education and treatment for high-risk patients. Psychological stress has been causally linked to exacerbation of chronic pain but has also been shown to amplify opioid craving in individuals with a history of opioid misuse and to increase the risk for opioid abuse. Using a steroid may increase the potential for adrenal insufficiency and altered immune response. Joint corticosteroid injection shown to be associated with higher risk of influenza. Duration of immune suppression could be less with the use of dexamethasone and betamethasone if applicable. Consider evaluating risk and benefit of steroid injection and using a decreased dose of steroid, especially in high-risk patient population.